Hi, this is Dr. Bob Dannenhoffer, Public Health Officer, sporting the new look in neck gaiters as a face covering. These work pretty well. This is just another way to express your artistic side, of which I have none. So anyway, Dr. Bob Dannenhoffer, the Public Health Officer, we're here with you again tonight for another one of our Facebook Live events. We're going to take any and all of your questions. We did get some questions over the time. Last week, somebody asked me about questions on anticoagulation. And that question is, I did look it up, and the story is in the people who have this disease, they frequently have clotting problems. Like in many serious diseases, people will have clotting issues, and the clotting issues are funny because in some places you clot too much, like in your kidneys, and sometimes in your veins or in your heart, and then other places you clot not enough. So like when you have blood drawn or have a procedure, you might ooze. So again, the clotting system was a very complicated system, really gets screwed up in this disease, and the information suggests that there needs to be careful attention to both overclotting and underclotting in this disease. So Mary, thank you for that question. So another question came up, are we still having a backlog of our tests? And the answer on that is yes, but it's getting better. So we did some tests on Saturday, and at that point, the tests from Tuesday were starting to come in. The ones from Friday were obviously not back yet, and the ones from the Saturday before were mostly in. So I would say our average turnaround time is now about 4 or 5 days, but sometimes it goes out to 8 days. All right, so they wanted me today to go over what the overall picture is with COVID in the world. And the picture is pretty grim. We're at about almost 2 million cases and 100,000 deaths. So really, this is a disease which is really taking its toll on the world. We're seeing disease in almost every part of the world. Only North Korea and Antarctica are places that say they don't yet have a case. Well, we think it probably will get there too. And so this disease is really spreading. 100,000 deaths is a lot of deaths because there are probably even some other deaths of people who died at home that we don't know. So this really is a big deal. In the United States, we saw a terrible week last week in New York, Connecticut, and New Jersey, starting to maybe get a little bit better there, but still a tremendous number of sick people and a tremendous amount of dying people. To put this in perspective, New York City is a dangerous city, and we worry about getting murdered in New York City, but there are 300 deaths a year for murder in New York City, so about 1 death a day. There was 1 death every 2 minutes from COVID on a single day. So we've lost far more people, 30 times as many people to COVID as to murder in New York City. So this really is a big deal in those areas. Still big issues in Louisiana, and in Michigan, especially around the Detroit area, and starting to be area problems in Indiana. So there are problems all over the country. Again, on the West Coast, Oregon, Washington, California, a little bit less of an issue than the rest of the country. Oregon has done remarkably well. We're the 5th lowest state in attack rates, and so that's a good sign. But we're not out of the woods yet. We've had 2 new cases yesterday in Douglas County. 3 new cases today. So this disease is still around. This is no time to let up. So a question came in, didn't we all have this in January? A lot of people were sick, had bad bronchitis, maybe even pneumonias in January. And every day I hear of 1 or 2 or 3 people who had that. And the answer is I don't know. The way we'll know is when these antibody tests come back. If you have high levels of antibodies, then you may well have had this in January or February. If you don't have high levels of antibodies, there was clearly something going on back then that was making people sick. And there's clearly stuff going on now that's making people sick. Because when we screen people, only 3 or 4% are positive, and clearly the other people are sick. So there's clearly something besides COVID going on. But these other things beside COVID don't wind you up in the ICU, and they don't wind up killing you, whereas COVID clearly does. So somebody asked a question about the drive-through in kids. And on the drive-through, we've limited it to people 15 and above. And the reason for that is we're actually reaching into people's cars to go ahead and do this test. And to do that, you really can't have to hold the person. Even we did a couple of teenagers in the last couple of drive-throughs that I've done. And even teenagers are a little dicey because they try and pull away at you and try and fight the procedure. And certainly kids would have to be held down, and there's no real way to do that through the drive-through. So for kids 15 and less, they really should be done in the doctor's office. and we understand that we'll use some PPE to get it done, but we think that's the safest way to do it. This is a distinctly uncomfortable test, and I don't think there's any way to convince a 3-year-old just sit still while I do this. They really do need to be held. Let's see other questions we have here. So we had we've had a small rush of positives in the last few days. Are they clustered like the previous tests along I-5, or is there a different spread? Well, some of these cases are associated with one workplace in Douglas County, but the other ones are kind of scattered around. They come from people all around. One actually was somebody from outside the state who got tested while they were in Oregon. So yeah, they are kind of scattered around. There is, other than this one workplace cluster, there is no other cluster. So are we getting negative tests that later turn positive? So the answer is not. So the story on this is we either get the results on the test as pending or negative or positive. We've not had any that were previously negative and then later turned positive. That's what the question is. So is the antibody test available yet? Now, you remember 2 weeks ago I said they told me it would be any day. And what I will tell you 2 weeks later, it's any day. So there are 70 different companies that are making antibody tests. There's one that's approved. And we keep telling here it's going to be any day that it's going to be shipped. And it still hasn't been shipped. So I'm sorry about that. So are we still getting 20 to 30% false negative tests? And the answer is probably, since we're using the same test that we're using before. And the false negatives come for 3 reasons. One is that there may not be very much virus in a person's throat at the time that they're sick. So the way you calculate the false negative rate is you said, if there was the perfect way to make the diagnosis, and then you did another test, what if there were people where you could do a perfect diagnosis, what percentage of the time is your test going to show a positive or negative? So the perfect test, we think, is to sedate somebody, to intubate somebody, and to do multiple testings of their bronchial wash fluid. So what you do is you put fluid in the lungs, you let it sit there, and you suck it out, and you do that 5 times, and then you test those 5 samples, and if one of those is positive, you consider the person to be positive. You then do a nasopharyngeal test, and you look on the nasopharyngeal test, and on 100 positives from the bronchial washings, what percentage of those would be positive from the nasopharyngeal swabs? And it's about 60 or 70% as compared to the 100% for the bronchial washing. And that's because this disease lives in the lungs, and so your bronchial washing is your most sensitive test. Not very much of it lives in the back of your throat, so the nasopharyngeal tests are going to have that decrease. It's the same exact test. So the test is the same. So it's not that the test has any false negatives. What it is that the sampling from that site has false negatives. So it's not the test which is wrong. It is where we're sampling it from. And unfortunately, there's no better way to get a sample from the lungs. Nobody would let you snake a tube down into their lungs. I had that done one time. It just would not work. So we have somebody in my house with all the symptoms of allergies, but with a fever. How long do we quarantine them? Well, allergies should never cause a fever. So if they have a fever and the symptoms of allergies, cough, runny nose, and whatever, they could clearly have COVID, and they should be home until they're all better, and then at least 1 day until all the symptoms have resolved. So I think the story on this one is it is not easy to pick out the difference of this and other diseases, especially if they have fever. You should never have fever with allergies. So it's safe to get takeout food? Yeah, I think Tammy asks, I think it is safe to get takeout food. So takeout food is produced at the restaurant. Presumably the people at restaurants are taking pretty good care of their hand washing to prevent other diseases like salmonella and norovirus and everything else. So I think takeout food is safe. I don't think there are any cases of the disease that have been associated with takeout food. So since you have to eat at some way, I think takeout food is probably a safe way to do it. So one of the other questions that came up again this week is, again, explain the difference with Douglas County and Douglas Public Health Center. What is going on there? So you'll see my shirt says Douglas Public Health. And so public health is a governmental function, and Douglas County is the public health authority for Douglas County. and I work for the county as the public health officer. But there's work that needs to get done, such as some of these other things that the county now contracts with Douglas Public Health Network to perform. So Vanessa and Kristen, who've been the call screeners here, work for Douglas Public Health Network at the request of the county. And so just like the county has other contractors that has to do its work, Douglas Public Health Network is the contractor that provides the services for the county. And being a public health network, a not-for-profit, has been advantageous. It, for example, has allowed us to get 2 big grants over the last little bit that governmental agencies would not have been eligible for. And it allows us to do things that a not-for-profit can do that the state or the county may not be able to do. So hopefully that explains it. If people have more questions about the dichotomy between the two, let me know. One of the other questions that came up over this next week is, when are we going to get back to normal? And so the question is, are we ever going to get back to the way we were 3 months ago? So 3 months ago, we flew back east on crowded airplanes, hugged and kissed a lot of people at Christmas time, a family where people shared drinks, a time where we didn't really think much about social distancing. It's going to be a while until we get back there. I think we're going to be thinking about social distancing. I think we're going to wear face covering. I think we're going to be nervous about flying on a plane for a while, at least until we get a vaccine. But can we get back to more normal than we are now? And I think we can. And I don't think we're going to say all of a sudden we've got this taken care of. We're going to go back to just the way it was back in December. But I think we can, over the next few weeks, the next few months, make some changes in the way we do things that people may be able to get more back to normal. And some of that back to normal may be school. Some of that back to normal may be sports. Some of that back to normal may be opening up restaurants. And how that's going to happen, I don't know. Washington, Oregon, and California signed an agreement today to work together to reopen the economy, to reopen things. And I'm hopeful that we're going to be able to get a little bit more back to normal, because this current situation of everybody staying at home is not, I don't think is going to work in the long run. So just to clarify, there are no better, easier ways to test for COVID. Is the nasal swab as good as it gets? So, people had talked in the past about just doing a mouth swab or spit or the throat swab. Those have much lower sensitivity rates than the nasopharyngeal swab. So at least in the short run, I do not think we're going to have a better way of doing this than the nasopharyngeal swab. So for example, we had talked before that if you had 100 people who you knew had this disease because you did a deep swab in their bronchial washings, and 100% of those would be positive. If you look in the nasopharyngeal swabs, it's only about 60 to 70%. You look in the throat, it's 30%. You look in the anterior nares, it's about 30%. And you look in a mouth swab, it's only about 20%. So as you start getting further and further away from the lungs, the sensitivity for this goes way down. And so I think at this point, nasopharyngeal swabs are the best we're going to do. So are the recovered still in quarantine? Shirley asks. So the story is that people have recovered, and they no longer need to be in quarantine. And there are a bunch of definitions for recovery. The definition that Oregon is using is that they're asymptomatic plus 3 days. And once you're asymptomatic plus 3 days, you can be out of quarantine. So what do we know about immunity? Can I get this only once? I'm pretty sure I had this in January. So we don't know that much about immunity for COVID because this is a relatively new condition. A study came out today suggesting that the immunity from SARS lasted 2 years. The immunity for some disease lasts a lifetime. So I had measles when I was a kid. I know I'm immune from measles. The immunity from hepatitis B, we think, lasts a lifetime. So some things can last a long time. Some things last. Then I'm sure I had it in January. The answer is I don't know. There's pretty good data that it was circulating a little bit in January, but all of those people who tell me they had it in January can't really be true because there just wasn't this much circulating on the good studies in the Seattle flu study. But the way we'll know is when the antibody studies come out. So I am totally recommending that anybody who thinks they had this in December, January, or February. When the antibody test comes out, you talk to your doctor and get one of the antibody tests. Can you only get it once? We don't know. There are other coronaviruses that cause common colds. We think you can get those multiple times, several years apart. Although pretty much once you get antibodies to those cold viruses, if you get it the next time, you don't get it nearly as bad. So we don't know about this one. Probably will have immunity at least for a while. And probably at least until a vaccine comes out. But this is the trouble. So that if the story is that, oh no, the immunity doesn't last very well, that would also suggest the immunity to the vaccine won't last very well either. And that then is ominous for development of a vaccine. So vaccines that produce lifelong immunity, like a measles vaccine, are the best ones because they produce a really strong response. If this one doesn't produce a strong response, then the vaccine won't work as well either. So there's worries of either too strong or too weak an immune response. So why does it take so long to get a vaccine made? And it takes a long time to get a vaccine made because you have to find the thing that your body will react to in a vaccine. So trying to describe this in a way, so let's think of a virus as being like a Rubik's Cube, and your body would respond only to one of the many variations of the Rubik's Cube. And there are a lot of different variations of a face of a Rubik's Cube, and you'd have to find exactly the right variation for it to be right. In addition, viruses have things that block the proteins that make an immune response so that your body won't make as good an immune response. So it is hard to find the thing to make the immune response. You know, we have spent billions of dollars and 40 years trying to get a vaccine for HIV, and we've not been able to do it. We've been trying for 45 years to get a vaccine for herpes, and we can't get it. So vaccines are really hard to make, especially if you're making a vaccine to a new thing. So does South Korea have a test that is 98% accurate? So again, the accuracy of these tests is related to the sensitivity of where you're sampling from. So we think the Oregon test is 100% accurate in terms of being, if you put enough virus in the test tube, it's both 100% sensitive and 100% specific. The problem with it is where you're sampling from. So the South Korean test is no more sensitive when you're swabbing the nasopharynx than the other test, but it's a very good test. And apparently they're going to send us 750,000 of those. But my answer on testing is I'll believe it when I see it. So does somebody have to actually get the disease to get immunity? And this is going to be a very interesting question. So if you look at those people who are asymptomatic or mildly symptomatic, do they produce good immunity? So we have 800 people who we know had this in February. And we know those who were asymptomatic, we know those about mildly symptomatic, and we know those who were sick. So I am hoping like crazy that somebody is testing all of those people who were on that Diamond Princess ship. So the Diamond Princess ship was a ship that docked in Yokohama, Japan. They found that there were a bunch of people on this, 800 people on this boat that tested positive. It will be so fascinating to see what their immunity is like. If you're asymptomatic, maybe your body didn't grow enough virus to make an immune response. So it may be that the asymptomatic people also didn't develop immunity. It may be, however, that they developed such great immunity that they never got symptoms. So there is so much to learn about this, and I really hope somebody's doing that study. I'm a little busy this week to do that study, but that would be the study I would love to do. So what should you do if you don't have a primary care doc and no insurance? And that is one of the tragedies in our country, is that everybody doesn't have health coverage. And another tragedy is everybody doesn't have a primary care doc. I heard today from the people at Evergreen said that if there are people who are sick and don't have a primary care doc and don't have insurance, that the people at the Evergreen Urgent Care will see you. So if you're sick, please get seen, because we don't want people to get sicker. So please get seen. And I hear the people at Evergreen Urgent Care will do that for you. So Lynn asked, do we know if those who test positive can still give it to others after they are recovered? And we think the answer is no. We think that once you're recovered, you're no longer at risk of giving it to others. The best would be to have a 100% sensitive test that would look at this, but we don't have that yet. So we think that you could be considered recovered if your symptoms are all gone plus 3 days, or if you're 7 days past your first test and your second test is negative. But far better to wait until all your symptoms are gone. So are the symptoms in kids different than adults? Ashley asks, and actually we do know the answer to that. In China, they looked at kids who had this, and in kids, this really does look like an upper respiratory infection. Upper respiratory congestion, some sore throat, some low-grade fever, some cough, occasionally abnormal chest x-ray, but almost never more than that in the thousands of kids in China who have this. Now, in adults, many adults will have those mild symptoms too, but some adults will start to have worse and worse symptoms, bad pneumonias, low oxygen levels, and wind up in the hospital and sometimes wind up dying. So one of the things we've seen in this outbreak in the United States is that people in their 20s, 30s, 40s dying. And that's tragic. I just saw one today, was a sports photojournalist who I really liked his work. 48 years old in New York, died. No underlying conditions, young family. That's a tragedy. So Dawn asks, can you explain how a ventilator helps once a patient gets to that point? So, we have lung disease. We're breathing oxygen in. And so when the first signs of lung disease, we can give somebody additional oxygen. But at some point, either the person tires out and can't move enough air back and forth, or there's not enough pressure to the lower parts of the lungs. And what a ventilator does then is it can both increase the oxygen level and increase the pressure to the bottom parts of the lung to hopefully do better. Ventilators also help, for example, in other diseases where, like in a spinal cord thing where you can no longer move your lungs, or in polio where you could no longer move your lungs, it would help in that case. But in this case, it helps by increasing the amount of pressure and the amount of oxygen to the lower parts of the lungs. But what I saw today, a study that suggested that this disease does not respond that well to ventilators, that about 2 out of 3 of people in Wuhan were on a ventilator died. In the U.S., it's more than that. So it's not magic. It's not like you put up people on a ventilator and they'll get better. There are certain diseases like that, like Guillain-Barré syndrome, where people have weakness. Ventilators are almost 100% saving. In babies who have ARDS, about 90% of the time they can get off, but in this disease, not so much. So we really don't have great treatment for this disease. We really have to wait. We really have to stop it in its tracks. So are any of the new cases here related to any of the previous cases, Evelyn asks? And the answer is there is a small outbreak in an employer here in Douglas County, and that employer is taking care of it. So yes, some of the new cases are related to previous cases, but most of them are not. Most of them are related to travel, or they just showed up and don't seem to have any other connection. So Diane asks, what's the determining factor of what an essential business that can stay open and which ones close? So in some times, people make a definition of essential businesses and not. The governor's order, and you can read this on the OHA website, the governor's order said that certain businesses should be closed, like gyms and hair salons and bars. But then other ones could be open if they could maintain social distancing without really declaring what's essential and not. So any business that can enforce effective social distancing and is not on that list can stay open. And so I'd encourage people to read that order, because I think there are some places that are closed now that if they read that order carefully could actually enforce social distancing and could stay open. So somebody says, I heard smokers are doing better fighting recovering from COVID, as strange as that sounds. Can that be true? I've not seen that. Actually, I've seen that smoking and respiratory disease actually is a risk factor for this. So I've not seen that smoking is protective, but I'll look that up tonight. So will the antibody test be limited to certain people and be done only by DPHN or also your PCP. We think the antibody test is going to be a very simple test that any PCP can do and won't require lots of PPE. So the reason that we're doing these drive-through clinics, anybody can do this test. So any doctor's office can do this test, but anytime, if I said, look, I think I have it, I want to get tested at my doctor's office, you need to get one or two people suited up in a full suit of PPE, and if they swabbed me, they would swab me, and then they would have to throw out that PPE, so it would use 2 full sets of PPE to test one person. When we do it in our drive-through, we can test 45 people with 2 sets of PPE, so it really saves the PPE. The antibody, and that's why we're doing these drive-throughs. If that was not the case, if you could do this without PPE, there would be no sense of doing the drive-throughs. The antibody test is a blood test. No PPE is required for the blood test, and so anybody should be able to do that test. So, do our frontline local heroes have enough PPE? So the story on PPE is that during regular times, you use a mask one time, you use a gown one time, you use goggles and then only when you need them, and we have plenty of PPE. During this time, people are doing extraordinary things to reuse PPE. They're using one mask for the whole day. They're using one gown for the whole day. I saw yesterday on TV that people were using plastic bags as PPE. So they clearly, our local EMT people and our hospital people clearly have enough PPE. Nobody is going without, but they're certainly not using it in the way that they used it before. So now in the hospital, people are reusing masks. And anytime you reuse a mask, there's a little bit additional risk because you have that mask on and then you touch the mask and touch your eyes, you can get it. So we have enough for now. We clearly don't have as much as we would like. So Heather asks, do we expect another huge spike? And I think the answer is no, we don't expect another huge spike. Will we expect cases to continue on? Yes. And will we expect the occasional outbreak in a place where you'll have a lot of cases? And the answer on that is definitely yes. So imagine we get to a point where in Oregon, we have 20 to 40 cases a day. So you could imagine 20 to 40 cases a day in Oregon, and in 20 to 40 cases a day, that would mean there would be the occasional person hospitalized. That would be the occasional death. However, if one of those 20 or 40 cases was in a prison, or one of those 20 or 40 cases was in a nursing home or the state hospital, you could then have a big outbreak and a huge local spike. So I think what we're saying is, I don't think we're going to have a huge spike all across the world, but we're clearly going to have little spikes in different places. And some of those spikes, depending upon what area they're in, could be quite big. So imagine if you had say a prison situation where there were 100 people in a dorm-like situation. You could have 100 cases in that dorm-like situation, and then it could spread out to the guards and their families and everybody else. So I think we might expect to see localized spikes, but I don't think we'll see a large spike in a place like New York. So are the positives self-isolating or in hospital? So 2 of the cases are currently in hospital at this point, and obviously they're in isolation there. The other ones are at home and they're self-isolating. And we check on them and we think they're doing a pretty good job of self-isolating. We're bringing them food and we're bringing them medicines and we're helping them out with their needs that they have when they're self-isolating. So we think they are doing a pretty good job on self-isolating. We have not issued any official quarantine orders. Official quarantine orders in Oregon are very, very hard to do, and they require multiple court hearings. So we've not done any official quarantine orders, but we think all of the positives are doing a really good job staying home. So Scott says, I read that the virus attaches to red blood cells, keeping hemoglobin from taking oxygen. Is that true? So there was this thread over the weekend that I read, and it was written, and it wasn't attributed to any doctor or any medical center, and there were a couple of misspellings and things that were wrong, but it gave the idea that this virus was somehow keeping hemoglobin from taking on oxygen, and that was the disease, and this really wasn't a pneumonia. Well, that doesn't seem exactly right, because clearly on CT there's a pneumonia. There's no question that a CT scan shows that these lungs are abnormal. On even a regular X-ray, it shows that clearly these lungs are abnormal. And if the problem was hemoglobin taking on oxygen, you should easily be able to test that, and that doesn't seem to be true. There are certain poisonings that do that. So there are things that do that, but this would be easily tested for. So although it sounded really scientific and like, wow, this could be interesting, when you read it further, it didn't seem to make much sense. But it's so interesting, I will keep reading it. The person who wrote that was a bit intriguing. So if we are not having any symptoms, is it necessary for us to wear a mask in public? So on this disease, we clearly know there's at least 4 excellent studies that people who were pre-symptomatic, so people before they had symptoms, went and gave this to lots of people. So a new one came out today about Biogen employees from Massachusetts. So the Biogen's a big company in Cambridge. And at this conference, there were people who were well at the conference, but by the time they got back home, they were sick, and they gave it to lots of people along the way. There's a couple of other very well documented cases that people who were not yet symptomatic spread it to lots of people. And the reason to wear a mask is like, I could come down with this tomorrow. I don't think so. I have not had any big exposures. But let's say I was coming down with this tomorrow, and then I went to the store today, or I went to work today without wearing a mask or didn't social distance. I could then be spreading it to other people. So for me to stop spreading it from other people in my pre-symptomatic state, and I'm not pre-symptomatic, but if I was, the best thing is social distancing. The next best thing is wearing the mask. And the mask is one of those things that is useful at a time where you can't be sure about social distancing. So let's say I had to take a flight somewhere. There's no way I could be sure that I could social distance on a flight. Let's say I had to take a cab somewhere. There's no way I could be sure to social distance in a cab. And there's no way I could be sure to social distance in the grocery store. I mean, I try to stay away from people in the grocery store or when I'm out shopping, but there's nothing to stop somebody from walking right up to me. There's nothing to stop other people from getting in the line too close. And because in those places where you can't assure social distancing, it does make sense to wear a face covering. And so wear a face covering. How much does it help? A little bit. It also makes people really aware that this is out there and we're still paying attention. When we look at the relative advantages of different things, the far and away, the biggest advantage is stay home if you are sick. Because people who are sick tend to cough, they tend to spread a lot of things. Stay home if you're sick. The next most important thing is social distancing. The next most important things are going to be to wash your hands and wear a mask. And the less effective things are out there. But far and away, the most effective thing, stay home if you're sick. Second is social or physical distancing. The third would be a mask and hand washing. So Donna asks, why aren't we using CT scanners to help us identify those who are sick? And the story is with the CT scan. So the CT scan is very sensitive. So if you do not have COVID, your CT scan is going to be normal, about 98% of the time. But they're not very specific. So unlike the nasopharyngeal test, which is not very sensitive but very specific, the CT scan is very sensitive but not very specific, meaning that there are going to be a number of people who have abnormal CT scans who will never have COVID. And they just have an abnormal CT scan because maybe they've got some emphysema. They may have an abnormal CT scan because they had some kind of infection in the past. They may have some other kind of viral pneumonia. And so what the CT scan will do, it will over-diagnose people who might have COVID who won't in the end. So any tests are useful if they're going to change what you're going to do. So in China, they use CT scans because if you had an abnormal CT scan, you immediately went to the isolation hospital, even if you wound up never to have COVID, and you went there until you were all better or they showed that you didn't have COVID. So for them, the CT scan was very useful. We're not going to do that in this country. We don't have isolation hospitals. We're not going to send everybody with an abnormal CT scan to the isolation hospital. So the CT scanners are not going to help us that much in what we do. And that's, I think, the reason we're not using those. So Jennifer asks, will the protocol of reusing PPE become our new normal? And I certainly hope not. I mean, reusing PPE is a risky thing, so that when you take on this 95 mask and you put it on, you're supposed to leave it on and then take it off and be done with it and dispose of it. I think reusing PPE is dangerous. And, it's certainly better than not having PPE at all, and that's why they're doing it. But I certainly hope that we don't get into the reusing PPE. PPE is not expensive. So, even these masks, now you see them on the internet for $5. They used to be 10 cents. So they used to be relatively inexpensive. And so I hope we don't get into the habit of reusing PPE. Everybody should have new PPE every time they do a procedure. That's certainly what I would want. And really, in a country as rich as ours, it's something we all deserve. So Sue says, are you concerned about the accuracy of the antibody test? And the answer is yes. There's a lot of concern. So in the past, if you would do a test, the FDA would be all over you to go ahead and to be sure that this test was very sensitive and very specific, and looked at the false positives and the false negatives and the positive predictive accuracy and the negative predictive accuracy. So all of these things would be studied, and they'd be studied in incredible detail, 97.38%, and we really futzed over the details. In this new world, with these emergency use authorizations, they don't have to publish sensitivities or specificities. And so there's a lot of concern. Big article in the New York Times this morning talking about concerns about the sensitivity and the specificity of these antibody tests, that they may not be that sensitive or specific, and that they may vary between them. So company A test may be different from company B's test and company C's test. So you might have the test done 3 or 4 times and get 3 or 4 different answers. And that's a big concern. Antibody tests are always a little bit worrisome to start with, because it's not like they're a strong. So, for example, mumps is one of those things where we don't make particularly great antibodies to. So people would do antibody tests to see if they have antibodies for mumps, and the normal and the level is 120 is considered positive. And so if you have more than 120, you're definitely immune. But what do you do with a test where if it's 0, then you're not immune? But what do you do with a number like 97? Are you immune, not immune? You can get it done a second time at maybe 121 or 68. So antibody tests are a little worrisome in that way, because if they're really high, you're protected. If your mumps test is 682, you're protected. Or if it's 0, you're not. But what do you do with those in the range of the 80 to 120? And I'm sure we're going to have the same issue with these. So Mary asked, what about thoughts on sterilization of masks? And you can sterilize both surgical masks and N95 masks. And there's a way to do that. And Mercy may be going there, a way to use ozone treatment to go ahead and do it there. It's actually really quite effective in getting rid of the germs. There are a couple of problems. One is ozone tends to degrade things, and so it can degrade the ties and degrade the other things in it. And the other issue with it is just it's sort of a hassle. You would not, we've never really thought about sterilizing masks. Remember, they're 10 cents a piece. Why would you go through all the hassle to sterilize something that is so inexpensive? And that's why we've gone to disposables. But I think the strategy that Mercy is using is actually quite reasonable. So what are the ages of the positives? So all of our positives are between 40 and 70, and ages of those in the hospital, I don't know the exact ages, but there's some in their 40s and some, the hospitalizations have been in all those age groups. So again, cases and hospitalizations sort of go together. Now, we think there probably are cases, people less than 40, but again, most of the people less than 40 have relatively mild disease, so mild that they may not even go to the doctor to get seen. And if they don't go to the doctor to get seen or come to the clinic to get tested, we're never going to know that they had it. So we think there probably are younger people who have this disease, have such a mild disease, it's nothing. And that's probably what happens. And that's why it's going to be hard to get rid of this disease, because for many of those people, it will be a kind of a nothing, but they can still move it on then to other people. So what we worry about is that those younger people getting it, people in their 20s, not particularly sick, who are working at a nursing home or making food at a nursing home or traveling or working as a driver and moving people to appointments. And we worry is that those people who, although they're not very sick with it, maybe a little bit of a cough or whatever, that they can move it to older people who, when they get it, really will get sick. And we think that's why there have been so many outbreaks at nursing homes. We don't think these are like old people who've come up with it on their own, or even visitors, because visitors have been banned from the nursing homes for several weeks. What we think it is relatively healthy staff members who are going to work, and these relatively healthy staff members then are giving it to older people, but when they get it, they have such a hard time with it. In those cases, actually wearing a mask might be helpful, because then they may be less contagious to that. But again, in nursing homes, it's really hard for people to do it. So I'm getting this message about our hotline. Our hotline has been great. We've been up now for over a month. We have the oldest COVID-19 hotline in the state. And it turns out that they must be doing a great job of answering questions, because the number of questions they're getting has been going down and down. And especially they've gotten very few questions after 5 o'clock. And so we're letting them off early now. So our hotline is running again every day still from 8 a.m. to 5 p.m. They tell me they usually get a lot more questions after this. So if you have a question after this, either put it on Facebook and I can answer it, or wait until tomorrow at 8 o'clock when they come. Their number, 541-464-6550. We're always looking for volunteers to help staff that hotline. Again, 541-464-6550. We have another drive-through tomorrow at the fairgrounds. Early on, we had many more requests for testing. We're getting fewer requests for testing each time. And so we're now opening up the testing to anybody the doctor wants. In the past, we'd said really try and focus on those people who are the highest risk, those people with fever, sick for 2 to 14 days. We've been able to loosen that up a little bit so that anybody the docs want tested, we can go ahead and test. Again, our rate of positives is very low. So in these clinics, our rate of positives is still less than 3 or 4%, which to me is a little bit surprising. I thought it would be much higher, but it seems to be relatively low. And we're doing these swabs exactly according to the thing. And anybody who's seen us do them, they really are disgusting. To put this swab in so far, leave it in for such a long time, and then pull it out. We're using only the best quality materials. So I think we're doing the best test as best we can. I think there's just not a lot of virus in people's nasopharynx. What is remarkable is that if you looked at a bunch of people, just random people through the day, you'd see a lot of people with runny nose and a lot of stuff in their nose. It was remarkable, all these people we screened, how few of them had anterior nasal symptoms, right? So we think of people with sinus infections with lots of drainage, green and bloody drainage from the nose. It is remarkable how few of these people have any drainage. So I don't know what's going on, but I think we're doing the testing about as best as we can, and that's what we got. So I'm seeing that the questions are petering out. That's a good thing. So again, if you have questions and we didn't get to them, sometimes we don't answer questions that we've answered several times in the past. Leave them on the Facebook Live, and sometime if I have a moment, I'll go through those and try and answer those questions. Again, we've been trying to be nice to people along the way, and people have been incredibly nice to us, sending us lots of nice things. There's some nasty stuff that occasionally gets on Facebook. Ooh, we don't really need nasty stuff. I mean, I could say a lot of nasty stuff about a lot of people, but I really try to avoid that. So let's try and be as positive as we can about all of these things. And again, I will try and answer those questions. A couple of things they asked me to remind you. Hotline, 8 a.m. to 5 p.m., 7 days a week. 541-464-6550. Testing clinic tomorrow at the fairgrounds. And have your doctor, if you want to get one of those tests, put it in. Now, if we do get a slew of requests, we can only do 45 at a time because of certain factors here. So if we get more than 45, we may need to use it for the sickest. But again, we've had not 45 requests for the last few times. And as of this afternoon, there was still quite a few openings. So if you want to get tested, talk to your doctor, and we'll see if we can get that. I think that's it. Again, this is Dr. Bob Dannenhoffer, Public Health Officer for Douglas County. And another with our Facebook Live. We'll see you again on Friday night. Thank you.